So my job is to make post-refractive surgery situations, IOL power complications simplified. So the bottom line is I'm not a nerd and I can't do too much with these calculations. So I will choose to keep it simple. And actually the newer biometry machines and formulae are kind of helping us to do that job. But still, we need to go back in history a little bit. I acknowledge the contribution of Dr. Sagar Bharwar, who lent me his slides and taught me a lot on this. So quick revision, biometry errors, axial length 1 millimeter error causes 3 diopter of post-op refractive error, keratometry 1 millimeter error would cause 1 diopter refractive error, and AC depth error of 1 millimeter would cause 1.5 diopter refractive error. Now, the problems with refractive surgery are standard keratometry methods, manual and autocorrect, do not apply because the corneal curvature has been altered. And the standard formulae also do not apply because the corneal power is taken into the calculations for the post-op refraction and also for the ELP. So it's a kind of double whammy. So the problem with refractive surgery is formula is if you input garbage, it's going to be garbage out. So we want to be very careful about what we input over here. So laser vision correction would be LASIK, PRK, SMILE, LASIK, and RK. That's another ball game. So let's see what the problems are with each one of these. Now, in keratometry, in laser vision correction, what happens, we are modifying the anterior curvature, corneal curvature, we're leaving the posterior curvature unchanged. So that means it alters the Gullstrand ratio of anterior posterior curvature based on which we have all our calculations this far. And so the standard keratometry measures only anterior curvature, posterior curvature is extrapolated based on the Gullstrand thing. So that gets kind of messed up. So this is no longer valid after laser vision correction. In radial keratotomy, we have a different kind of problem. We have a small optical zone. Though the ratio is maintained between anterior and posterior curvature, we have a small optical zone. There is a diurnal variation in refraction, irregular astigmatism, and we can have a surgical, after we do the surgery because of hydration of the cornea, we can have a flattening which will take months and sometimes years to resolve. So the other problem with laser vision correction and radial keratotomy is the radius zone error. So all our automated keratometry measure instruments provide the central 3 to 3.2 millimeters measurements, but that is where things change. In myopic LASIK, we have already created a larger optical zone, and in hyperopic LASIK and RK, we have made the zone smaller than 3 millimeters sometimes. So in post-RK, the corneal changes are that basically what was spherical and had a fixed ratio and a standard optical zone has become a small optical zone and centrally, and it's got flattened centrally completely. Though the Gullstrand ratio is maintained, the optical zone is small. So, and the refractive effect can change over time. With post-LASIK or PRK, what the corneal changes that we have are basically we have a larger optical zone, an altered ratio, the Gullstrand ratio is altered, and that we have a flattened anterior chamber, which have a wet anterior curvature, which actually leads to all that. In hyperopia, again, it's a kind of mix of both the problems. It's a smaller optical zone, altered anterior curvature. It's a kind of mess with both the factors being in play. Now we come to the effective lens position. So all IOL calculation formula differ in the methods but of estimating ELP, but most use the corneal power at some point in the time. So let's say what happens over here. In myopic ablation, there is a reduced corneal power. Formula incorrectly assumed the anterior chamber is shallower, which gives us an anterior ELP, and we have an underestimation of IOL power, which results in a hyperopic result. So what is the remedy to our problems? So post-laser vision correction, what we would like to do is directly measure both anterior and posterior corneal curvature exactly, not by extrapolation, and get the net corneal power. That would help us. In post-RKIs, we need to factor in the fact that we're dealing with a smaller optical zone and need to calculate what is the effective optical zone that we're dealing in that particular eye. So when it comes to K reading solutions, we have corneal topography where we take the SIM-K, slightly older, not used too much, but used in certain machines still. Scheimpflug photography has been used for some time. The EKR, the equivalent K reading in the Holiday report gives us a measure. We'll come to that. We'll come with diagrams on that. And the total corneal power. That is actually, sorry. So the total corneal power or the true net power is a software calculation from the corneal vertex power. Now, OCT, when you have that incorporated in certain machines, and that OCT has to be for the corneal measurements, so that you get a high resolution OCT of the anterior and posterior curvature, that can give you a much better idea of the true corneal power. Now let's come to the EKR. Now this is a case of post-radial keratotomy. Now look at the range in which the EKR, there's a wide variation in the distribution over 12.7 diopters in the EKR values over the 4.5 millimeter zone. So it's a huge variation. That's what leads to trouble. Now in post-classic eye, that variation is relatively small. It's over a kind of 3.3 diopter range, and that is more favorable. So you will have to factor this in your calculations. Now, K-reading solutions for biometers, we have different options over the generations of these biometers. Lenstar uses 32 reference points. IOL Master 700 uses something called telecentric keratometry, and a SWEP OCT. That has a huge advantage. The Tomy uses topography simultaneously at 2, 2.5, and 3 millimeter diameter optical zones. I have a Tomy myself, but the IOL Master has certain features which would help you in kind of post-laser vision correction. Otherwise, most of the machines work very well for other things. So let's talk about total keratometry. It's a new thing, and we must know about it because it's a very good option for post-refractive surgeries. So this considers the corneal thickness and the posterior corneal curvature in addition to the anterior corneal curvature, which most other instruments do. So what is measured is the total keratometry by telecentric keratometry measurement of the anterior corneal surface. A swept source OCT is used to measure the posterior corneal surface directly, and a corneal pachymetry is also incorporated in the calculation. So TK is designed to be equivalent to the K readings in order to enable its use in the standard IOL formulae. So formula solutions. Now, standard formulae have major issues. They were you could use either correcting the formula or the result. It's kind of fudging it, but that really doesn't work now. So we have the Barrett-Truquet, I think, which most people are using. So for patients who have used had myopic or hyperopic LASIK or radial keratotomy, it's based on basically the sheet anchors, the Barrett U2, Universal 2. It calculates modified keratometry value and requires the measured keratometries and refraction history, kind of before and after laser. Barrett suite is again a combination of Barrett U2, Barrett Toric, Barrett Truquet, Barrett TK Universal 2, and Barrett TK Toric. You can read this up all later. So we'll come to now what has happened in the last couple of years, couple of publications since the last AIOS. So the Barrett 2K, this is a publication by Lawless and colleagues, and the Barrett 2K TK provides the lowest, Barrett 2K provides the lowest mean refractive prediction error in both prior myopes and hypermyopes who have undergone cataract surgery. Now that's the distribution, Barrett 2K TK, and this is for the formal with others for no history measurements, and here we found the EVO TK and Barrett 2K. Good. Yeah, I'm finishing. So the best would be, if you do not have access to the formula, go on to the IOL ACRS, and you can just input your formula and the figures, and you would get various calculations and use that according to what is available and how much history and how much data you have. The more the data you have, the better it is. So to conclude, my recommendation would be good history and counseling, take a proper consent, try total keratometry as far as possible, and optical biometry as far as possible. Thank you, and sorry for exceeding the time.